I will try to be brief so that everybody can get to asking any questions. I'm going to start out, I'm usually the guy that sucks the air out of the room and everybody leaves depressed. I'm going to start out with something positive before we move on to the meat of what I'm going to talk about. And I'm going to start out kind of with the context, because when you talk about health care and health policy, you have to talk about the Affordable Care Act. It's what's hovering up here above everything. And the positive that I want to say is that you might not have heard this, but by all reasonable measures, just about, the Affordable Care Act is a great success and is doing everything it was designed to do. Okay, I want to give you some examples. When health policy people like me talk about health care, we look at access, we look at quality, and we look at cost. And in all of those areas, we're seeing huge improvements over the last few years in our healthcare system. In terms of access, the latest surveys, which are actually, everything I'm going to talk about in terms of the latest research came out last week, so we were talking about up to the minute. The latest surveys show that we have about 10 million fewer uninsured people in this country now than we had a year ago. Okay, that is 20 to 25% of the total number of uninsured. That is a huge chunk in the first year of a program. Here in Kansas, we don't have great statistics for what's going on in states and locally. What we know in Kansas is that we enrolled 57,000 people last year in the health insurance marketplace. If what's going on in Kansas is similar to what's going on in the rest of the country, we can assume that 50 to 60% of those people were previously uninsured, which means we have about 30,000 fewer uninsured in Kansas than we did at this time last year. And I'm going to talk in a little while about Medicaid expansion. That number would be much higher if we had a Medicaid expansion in this state. In terms of quality, a study came out last week. One of the things the Affordable Care Act tries to do is create incentives for providers for better quality of care. Over the last 4 years, we have had a decrease in hospital-acquired conditions. These are infections that people get when they go to the hospital. We've had a decrease of 17%. What that means is that we have 1.3 million fewer hospital-acquired conditions than we would have expected, and that translates into about 50,000 fewer deaths. So there's about 50,000 people alive today who we would not have expected to be alive if we had not implemented these changes. And I want to put that in perspective. We are coming out, or we're probably still in this Ebola terror, this Ebola scare, that in this country, 1 person has died of Ebola. In Africa, it's between 3,000 and 4,000. We're talking about 50,000 people who are alive today who probably wouldn't have been alive 4 years ago under the old system. And then finally, cost, which is really ultimately what this is about. All the predictions about the explosion in healthcare costs as a result of Obamacare are absolutely wrong. Last year, healthcare costs in this country went up by 3.6%. That is the lowest number since we started collecting this data in 1960. Okay, healthcare costs are going up slower than they ever have. And that means that healthcare is now growing at the same rate as the rest of the economy, which means that every year we're not spending more on healthcare and having less to spend on anything else. If you look at the long-range health of the Medicare budget, if you look at the long-range health of the federal budget and the deficit, that is a huge number that I just told you, because the reason we have a federal budget deficit is because of healthcare costs. If our healthcare costs were growing at this rate for the last 30 years, we wouldn't have a budget deficit. Okay, so this is huge. Now, that's not all because of the Affordable Care Act, but part of it's because of the Affordable Care Act. You know, I'm having to deal with people now. For the last 4 years, I've dealt with people telling me, oh my God, the ACA, it's impacting everything we do. It's having an effect on everything. Now I'm having people tell me, oh, but it's not doing anything about healthcare costs. Well, you can't have both things, okay? The ACA is a big factor. The only other thing I'll say about the ACA is we are in the middle of the second open enrollment period. It continues through February 15th. We have a big effort here in Kansas For outreach and enrollment, to get people enrolled, we want to exceed the number we hit last year. We are going to have about 160 trained navigators on the ground by the end of the open enrollment period. If you're in an organization that either wants to have a navigator or otherwise wants to help, you can send an email to coverkansas@kspca.org. Okay, that concludes the positive part of my presentation. And let's move on to what we are likely to see here in the legislative session in 2015. A couple of minor things before I get to the big 800-pound gorilla. So first, we're going to still hear a lot about CanCare improvements. We all know about CanCare, which is our managed care-based Medicaid program. For the last few years, it has been run entirely by private entities. We were the first state that essentially put all of our Medicaid populations into managed care. And it's chugging along. There are still problems with providers getting paid the right amounts. There are still problems with people easily being able to access the services they need. Maybe the biggest problem that's sort of lurking in the background is that the managed care organizations are all losing money on these populations. At some point, I assume that's going to matter. Now, my opinion is that these are big national managed care organizations. They're going to be willing to lose money for a while in Kansas. They want to learn how to handle these populations so that when other states look to us and maybe do what we did, these companies might be in a position to take care of these populations. And the big money, frankly, is not in Kansas. But at some point, it's going to matter. They're big national companies. They're traded on Wall Street. Their investors are going to care. So we're going to be talking about CanCare improvement. We may again see this year. Last year we saw a bill in the legislature that would have regulated ACA navigators. It would have put restrictions on what they do, would have largely shut down the program. I mean, there were things like having them register with the state and pay a registration fee. That's one thing. There was also a provision of the bill that would have prohibited navigators from referring their clients to any websites. Since you have to go to healthcare.gov to sign up for insurance, that would have pretty much killed the program. That bill passed the Senate and died in a House committee. We may see that again this year, and we will have to marshal the forces again to try to get it. Another thing we may see this year, and I don't know that I need to tell the Johnson County audience much about the healthcare compact, but that's looming out there. As you all know, last year the state passed and the governor signed a compact that allows the state of Kansas to take over any and all federal healthcare programs. That bill will now go to the full Congress. And if the Congress chooses to pass it, there's some debate about whether or not the president has to sign it. I'm not qualified to really answer that. But I think the way the compact was designed by its originators was that it would not have to go to the White House. If it passed the Senate and the House, it would then come back to the state, and the state legislature could decide which, if any, federal health programs they would like to take over. And I would urge all of you to read the compact. It's only 4 pages. It's pretty easy to read. And I want to put to rest a lot of the things that you guys were arguing about a few months ago in Johnson County. And I don't even know why this was in dispute, because it's a 4-page bill. Anybody can see this. Is Medicare included in the compact? If the state chooses, then yes, it is. And is there any requirement in the compact that the state would use all the money the federal government sends only on health care? No, there isn't. So the way the compact is designed is that the state would go and say, we're going to take over Medicare and Medicaid. The federal government would write a check for what those programs would cost, send it to Topeka, and the legislature and the governor could use that money for anything they want. Okay, that concludes my healthcare comment. I'd be happy to answer questions about it if you have. Let's move on to Medicaid expansion. Medicaid expansion is the big health policy issue in Kansas. It should have been the big health policy issue in Kansas for the last 2 years, but we have not discussed it. In the last 2 years, we've had 1 hearing in the legislature on Medicaid expansion that lasted 1 morning. So a couple of things going on. The big thing is, will it even get a hearing? Okay, we're going to have some new leadership on our committees this year. We don't know who those leaders are going to be yet, and who the committee leaders are in the health committees will largely determine whether or not we get hearings on this bill. We don't know who that's going to be yet. If it gets a hearing, then we're going to have a lot to talk about. There's a lot of things going on. The Kansas Hospital Association, which has sort of been quietly trying to push for this over the last few years, is going to be much more forceful this year. They are developing a plan that they will present to the legislature that is based on some of the private models that are being implemented in some states where you would not see an expansion of the traditional Medicaid program, but we would see an expansion that's somehow based on private insurance. Whether it's an expansion of CanCare in the existing managed care organizations we currently have, or whether it's an expansion by buying into the plans that people can buy in the federal marketplace. We don't have details yet, but it'll be one of those options. What we're going to hear about this as a pushback is that we have no money. We saw Annie's numbers. We have no money. Okay, and through next year, the Medicaid expansion is at essentially no cost to states. After 2016, states are going to have to start kicking in some money. It starts out at 5% of the cost and eventually gradually changes to 10% in the year 2020. Now, a 90-10 match in most programs, if I gave you the deal of give me $1 and I'll give you 9 in return, most people would take that. So far, that's not good enough for us. And so we're going to have to change the way we discuss this. So one of the things the Hospital Association plan is going to do is coming up with a plan for paying for it. And there may be ways to construct a payment that it actually won't increase the state budget. Some other states that have already done this and have done some analysis of this have looked into other pieces of the state budget aside from Medicaid and found savings that can fund Medicaid. I mean, we pay for health care for the uninsured in a lot of different parts of our state budget. We give grants to safety net clinics to support people who don't have insurance. We give money to local health departments to support people who don't have insurance. We've got a pretty unique hospital system here in Kansas where the majority of our hospitals in Kansas are publicly owned. They're owned by the cities and counties largely where they exist, mostly in rural Kansas. They are supported by local taxes that you wouldn't believe if you saw the numbers, largely because they have to support people who are uninsured. Especially when you get to Southwest Kansas, there are huge rates of uninsurance. There are counties in Southwest Kansas where uninsurance is close to 30% of the population. Local communities are funding those themselves in property taxes and other local taxes. We may be able to find some savings there. So there's a chance, and we'll get more numbers as we go through this, that Medicaid expansion will actually pay for itself. And that's what some of the other states are finding. Yeah. So as we move forward and figure out how we're going to advocate for this, I mean, I'm gonna echo what Melissa said. I don't know how to advocate for this anymore. I mean, it used to be that we would build coalitions, we'd include all the important people, businesses, healthcare providers in this case, philanthropies. We'd have good stories, we have a lot of data on our side, and that would carry the day. I don't know that that is the trick anymore. I honestly don't know what the trick is. And so, I mean, I think there is some education that we can do, though, sort of in the traditional sense of how we've done advocacy. Medicaid is a very misunderstood program. I mean, if most people who aren't that familiar with it assume that it's a program for poor people. And that's about half true. It is not enough to be low income to get into the Medicaid program. You have to be low income and you have to fit into one of the program's categories. So you have to be low income and disabled, or low income and pregnant, or low income and a child. If you're simply low income, if you're an able-bodied adult with no children in Kansas, you can't be in Medicaid at all, regardless of your income. And even if you are someone who fits into one of the categories, so a mother with 2 children, single mom with 2 kids, can get into Medicaid if she makes less than 32% of the federal poverty line. That's about $6,500 a year. To translate into something that you can understand, a single mom with 2 kids working at a minimum wage job half-time is too wealthy to qualify for Medicaid. That's why we need a Medicaid expansion. Because one of the things the Affordable Care Act tried to do is get rid of a lot of those categories that keep people uninsured. And so we need to do education about what Medicaid really is. We need to do education about the advantages of having health insurance. We know that having health insurance, including Medicaid, improves people's health, and it improves their financial condition. And so when people ask me what they can do, I'm telling everybody to contact their legislators early and often. If you're concerned about this issue, call your local legislator every single day. We have to make our legislators and our governor uncomfortable that Kansas is in the minority of states that is not expanding this program. And we're seeing some interesting data coming in the states that are expanding this program, okay? If you look at the number of people and the proportion of people that are uninsured, we have a huge difference in this country now between states that have expanded Medicaid and states that haven't. States that have expanded Medicaid have an average uninsurance rate of 10%. States that have not expanded Medicaid have an average uninsurance rate of more than 16%. States that have not expanded Medicaid are not seeing financial help come to their health care providers. If you look at uncompensated care in hospitals, it is plunging in states that have expanded Medicaid. It is going up in states like Kansas that have not expanded Medicaid. One of the things that's interesting, and this is a piece of data that here in Kansas may carry some weight. If you look at investor-owned hospital corporations, and we have some here in Kansas, these are companies that are traded on Wall Street. They're seeing much better financial results in their hospitals in expansion states than in non-expansion states. And that's because they're seeing many, many fewer uninsured people. And so we're having a lot of data come in that, again, in normal times I would have said that this data would be overwhelming and carry the day. I don't know if we're in a time where data matters. And so I'd actually be interested in what everyone else has to say about how to do advocacy. Otherwise, turn out. If we do have a hearing on Medicaid expansion, this is an issue you're interested in, turn out, talk to your legislators before the hearing, and come to the hearing and testify. And with that, I will be happy to take questions.
With the reference of calling early and often, that's important. I don't know that daily, I think that was a jest, but if you call every day, you're going to get written off as a crazy person and ignored. So take that with a grain of salt. So we can maybe talk more about that. But who's got questions? Yes, sir.
Sheldon, this is for you. You didn't mention the Supreme Court ruling coming up pretty soon. Would you elaborate on that for us?
Okay, and I'll stand up so everyone can hear me. I didn't mention that because we don't know what's going to happen. But the Supreme Court will be hearing a case probably in March with a decision coming in June on what could be a serious threat to the Affordable Care Act. And what the case is about is whether the federal government is authorized under the law to provide tax assistance for people to buy insurance who purchase insurance in federal marketplace, like Kansas. So we have about 18 states that are doing their own marketplace, and the rest, like Kansas, has turned it over to the federal government. There's a section of the law that talks about assistance in state marketplaces. And some opponents of the law have latched onto that and said the law clearly says assistance goes to those in state marketplaces, not federal marketplaces. The rest of the law does not make that distinction, but one section clearly does. And so the Supreme Court will be deciding whether that one section of the law determines whether the federal government is authorized to provide assistance in federal marketplace states. If the Supreme Court rules that the federal government may not provide that assistance, then everybody who buys insurance in a federal marketplace state like Kansas will no longer be able to get tax credits to help them pay for insurance. In Kansas, that was 80% of the people that purchased insurance. So what we're likely to see if that happens is a couple of things. what you typically see what happens in situations like that, people no longer will get assistance, so most of them will no longer be able to afford to buy insurance. So lots of people will drop out of the insurance market. Not all of them will drop out. The people that will remain are the people that really, really need insurance, people who are currently sick. They will find a way to scratch together the money they need to buy insurance. That will mean that the insurance pool, the group of people that's insured by insurance companies, will be sicker than it used to be. That means that prices will go up. That means that more healthy people will drop out. That means that prices will go up even farther. This is, you might have heard over the years, the insurance industry concerned about something called the death spiral. That's what I just described. That is a possibility of what may happen depending on that Supreme Court ruling. It goes way beyond just people who buy insurance in the marketplace. It ultimately will affect everybody who has private health insurance. And so that's a big possibility. If the Supreme Court rules that no, the federal government is within the law to provide those tax credits, then we will just continue along as we have.
What's your probability of them accepting or not accepting?
I am not going to predict that. All I can say is that there had to be at least 4 Supreme Court justices who thought this case had some merit for them to accept it. I'm not an expert. I'm not even a lawyer. We have some lawyers.
But you play one on TV.
I could. From what my reading from there's not a whole lot of federal and constitutional law experts who believe this case has much merit because of lots of previous precedent. Nevertheless, that doesn't mean the Supreme Court won't create a new precedent. And so the Supreme Court is the one court that can go against previous precedent and change things. And so it is kind of the last existential crisis for the Affordable Care Act, and it's a big one.
Paul in the back.
Just for you, Sheldon, how many states have a premier flagship hospital like the KU hospital? And is that a piece of infrastructure that can be sold in this state, as well as maybe the Kansas Turnpike Authority? Since privatization seems to be the key attitude of this government?
That's an excellent question. I'm not sure I know the answer to. Most states have at least one hospital like KU Hospital. It's considered a flagship institution. The bigger states, Massachusetts, New York, California, have many. Some of them are public entities, some of them are private entities. KU Hospital is sort of a quasi-funny kind of public-private entity. I don't know if it can be sold.
They're always from funded through their own revenue system. The hospital is different than the medical.
Right, but the hospital has agreements with the medical center, so.
Short answer, we don't know.
We
there has been talk, of course, about privatizing the Turnpike Authority. I think that very much can be done, whether there's any initiative to do it.
I think I can say pretty confidently it wouldn't be easy to do that. To untangle KU Hospital from KU Med in the medical school would be really messy. The organization in Kansas that is one of the organizations that's involved in the Medicaid expansion effort is the Kansas Health Consumer Coalition. They are at kshealthconsumer.org, I guess? .org? Google it. And I think if we're going to have a successful effort, I think it's going to be the effort that's led by the Hospital Association. So I would encourage you to join forces with your local hospital and talk to them about how you can do advocacy around Medicaid expansion.
Yeah, I have a Medicaid expansion question. It has been published that the cost, so to speak, of Kansas not accepting Medicaid expansion in terms of federal dollars are not repatriated back to Kansas is about $350 million a year. Assuming, for the sake of argument, we just keep that number flat out to the year 2020, when the state would have to pick up 10%, that would be approximately $35 million, with essentially $315 million being contributed. Has anyone done any studies looking at the economic effect on tax revenue for that additional $315 million a year that would be coming in as an offset to the state portion.
Yeah, so the Hospital Association, about a year ago, contracted with actually a very reputable organization. They did not do the study themselves. They contracted out to George Washington University and an organization called Regional Economic Models, and determined that the federal money flowing into the state would, over time, eventually create about 4,000 new jobs. And if you roll the revenue that would be created from those new jobs and the additional business impact of that, that it essentially pays for itself. And so, and that's what, again, those sorts of analyses have been done in every state that's expanded Medicaid, and they're all projecting the same results. It's too early to tell if that's what is really going to happen, but nobody has really gotten any different results. And so that's why I was talking about it's very possible this pays for itself through a combination of additional revenues coming in through job growth and economic activity and reductions on other places in the budget. Good point.
Gordon, do you have a question?
Yeah, just to kind of follow up on his, if you've got that 300 and some million coming in, from a budget standpoint, we've got this $1 billion hole over the next 2 years. Does that do anything to lessen that?
I think it certainly would help.
What's interesting on that's a great discussion. That's an argument that, I mean, the reason that we've all talked about that is because that's an argument that a lot of folks assume would really hold some weight in this environment. I have spoken to legislators about this, and there is a belief that federal money does not contribute to economic growth. And so when you're dealing with that, it's hard to make that argument. And that's kind of where I am when I say I don't know what kind of advocacy works. K-State Extension is involved in training their local extension agents to help people enroll in plans in the marketplace. There's a lot of counties in the state that will not let their extension agents work with their local citizens to enroll people in insurance in the marketplace. These are the same agents that work every single day with farmers and ranchers, signing them up for federal crop insurance and other subsidy programs, and they are not allowed to work with their constituents on health insurance. Now, I don't know that it's productive to throw that back in their face, and so I think I would return to what Melissa just said, is we have to think of a way to reframe that in a more positive way, but you're absolutely right that that's what's going on.
I hate to go back to Medicaid expansion, except that what I hear is that this makes a real difference in rural communities with rural hospitals, and that's really important to keep them open. But what difference does it make in Johnson County?
In a state like Kansas, you're going to hear a lot about rural hospitals. In some states, we're having a problem with rural hospitals closing because states have made the decision not to expand Medicaid. Georgia, I think, has lost 4 or 5 hospitals. I don't think in Kansas we're likely to see hospitals close because of a lack of Medicaid expansion. And I'm glad you asked the question, because the real impact of changes are going to be on the hospitals that are in more urban communities, the larger hospitals like the hospitals in Johnson and Wyandotte County, the hospitals in Wichita. So what's going on is that there was a trade-off made in the Affordable Care Act. Hospitals agreed to smaller increases in their Medicare payments every year in exchange for more insured patients. They're seeing those smaller increases in Medicare. They're not seeing those more insured patients in states like Kansas that aren't expanding Medicaid. And so the real impact is actually, I don't think, going to be in our rural hospitals. It's going to be at KU, it's going to be at Via Christi, and it's going to be at the big urban hospitals like that. It's going to affect everybody, but I think in terms of kind of the proportion of the impact, it's going to be bigger in the urbans. So I mean, I don't want to lose that point. The rurals, it kind of depends where they are. There are some parts of the state of Kansas where there just really are not a lot of people that qualify for Medicaid. Some parts where there's a lot. It just it depends.
On a different topic, there's been some talk recently, as recent as the election, about potentially carving the developmental disability population out of CanCare. Is that issue dead now?
You know, as CanCare was rolling out, initially everybody was going to be put in it first. The developmentally disabled and intellectually disabled population was carved out for a year. Their medical services were included. What was carved out were the social services and supports. I have no doubt the advocates are going to continue fighting to try to get them carved out, but I haven't heard that that's something that's likely to happen.
My question is, with regard to CanCare and the MCOs, are they really losing money or is it less profit?
Oh, no, they're losing money.
They're really losing money?
They're losing money on Kansas Medicaid, absolutely.
Then let's go to the senior care. They're really pushing to close or reduce long-term, highly skilled nursing home occupancy and replace it with home care, hospice care, whatever. And this is an MCO expansion. So is this going to be profitable or is it going to erode further into their losses?
Well, so when you look at nursing homes, I mean, one of the interesting things is most people don't realize most nursing homes get most of their revenue from the Medicaid program. So they're largely state-supported facilities in that respect. Medicaid nursing home services are very costly because when you think of the frail elderly and how sick you have to be in a nursing home, those are people who need a lot of care. They're very costly services. And so in kind of the big picture, long range, and this is not unique to Kansas, every state looks at downsizing nursing homes as a way to save some of those costs. Now, what has to be done is we have to create those community-based services to fill in that hole. That's going to take some of those cost savings and we're going to need to reinvest them. That didn't work so well with the mental health population. So we're going to have to do a better job with the nursing home population. But I think as we look long-term, I don't care if we have an MCO managed Medicaid program or it goes back to a state-managed program, that's going to happen anyway. We're going to see a long-term emphasis on getting people out of institutions because that's where the big money is. And whether or not we're successful in creating those community-based services is going to determine how well we're caring for our elders in the future. If we do it right and it works, it'll save money. But no one's really done it right yet. So.
County.
Strong man, thank you.